If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll look at the NICE updates published in September 2025, focusing on what is relevant in primary care only. In recent months, there hasn't been much in the way of updates that affect us in general practice. But September is very different. There's a lot that we need to pay attention to. These updates cover eczema, respiratory infections, pneumonia, bipolar disorder, tirzepatide, and importantly, a new updated guideline on chronic heart failure. Right, let's jump into it. The updated NICE guideline on atopic eczema in children under 12 has revised the section on complementary therapies, washing and clothing. The new wording makes it clear that children with atopic eczema may bathe or shower once daily. Bathing can help remove crusts and skin debris and improve comfort, but it should always be followed by emollient application to prevent the skin from drying out. The update also clarifies that water softeners and silk garments do not improve eczema severity and therefore should not be recommended. So, in summary, daily bathing is acceptable and can be beneficial if followed by emollient use, and water softeners or silk clothing should not be recommended. The next section is on chronic heart failure. The updated NICE guideline has introduced substantial changes, particularly to how we treat and monitor different categories of heart failure. This is such an important area that I will only cover the highlights today, and I will cover it in more detail in a future episode. The main focus of the update was the drug management of the three subtypes of heart failure, that is, heart failure with reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. For heart failure with reduced ejection fraction, that is, an ejection fraction 40% or less, the recommendations now reflect strong evidence for SGLT2 inhibitors, which consistently reduce hospitalizations for heart failure and improve survival regardless of diabetes status. These drugs are now embedded alongside established treatments such as ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists. For heart failure with mildly reduced ejection fraction, that is, an ejection fraction between 41 and 49%, NICE issues new recommendations for the first time. This group used to be a bit of a grey area. The update highlights evidence that people with mildly reduced ejection fraction may also benefit from SGLT2 inhibitors in much the same way as those with reduced ejection fraction, and the guidance now advises considering them here too. For heart failure with preserved ejection fraction, meaning an ejection fraction of 50% or more, NICE also makes new recommendations. In the past, management was mostly limited to controlling symptoms and comorbidities. Now, on the back of trial evidence, SGLT2 inhibitors are also recommended here because they reduce hospitalizations for heart failure, even if mortality benefit is less certain. In practice, this means that SGLT2 inhibitors will be used more widely, not only in people with reduced ejection fraction, but also in those with mildly reduced or preserved ejection fraction. An updated NICE quality standard on chronic heart failure has also been published to reflect these changes. Next, there's a brand new NICE guideline on pneumonia, which consolidates and replaces previous guidance, including antimicrobial prescribing guidelines. The biggest change for us in primary care relates to children. The recommended course of antibiotics for non-severe community-acquired pneumonia without complications or underlying disease has been reduced from 5 days to 3 days. This is because new evidence shows that shorter courses are just as effective at resolving symptoms, while reducing the risk of side effects and, most importantly, lowering the risk of antibiotic resistance. Additionally, although more relevant to secondary care, there are new recommendations on corticosteroids in patients with high-severity community-acquired pneumonia when admitted to hospital. This reflects growing evidence that systemic steroids can improve outcomes in severe cases alongside standard antibiotic and supportive care. However, corticosteroids are not recommended for routine use in mild or moderate pneumonia. so it is something that we will not be doing routinely in primary care. There's also an updated quality standard on pneumonia aligned with the new guideline and reflecting the changes I've just mentioned. Next, we have the updated NICE guideline on suspected acute respiratory infection, which covers assessment as first presentation and initial management. The main change here is that the section on the clinical diagnosis of community-acquired pneumonia in primary care has been removed, because that information is now fully covered by the new pneumonia guideline. In practical terms, pneumonia-specific recommendations move to the pneumonia guideline, while the guideline on respiratory infections continues to provide guidance on the assessment and initial management of these infections more broadly. These guidelines should also be read alongside existing antimicrobial prescribing guidelines for acute cough, COPD exacerbations, sinusitis, and sore throat. The latest update on the clinical guideline on bipolar disorder focuses on recommendations around valproate use. Following new safety advice from the MHRA, the key change is that boys and men taking valproate must now be advised to use effective contraception throughout their treatment and for 3 months after stopping. This means using condoms in addition to contraception used by a female sexual partner. Additionally, men who are planning a family within the next year should also discuss potential fertility risks and alternative treatment options. Previously, recommendations were already strict around valproate use in females of childbearing potential. Valproate must not be initiated in anyone under 55 unless 2 specialists agree that there are no other suitable alternatives or that the reproductive risks do not apply. For them, it can only be prescribed if other treatments are unsuitable and the pregnancy prevention program is in place. The new update now extends this caution explicitly to male patients, confirming that valproate carries reproductive risks for both sexes. Finally, there are updates to the NICE technology appraisals on tirzepatide, marketed as Mounjaro, covering both type 2 diabetes and the management of overweight and obesity. The recommendations themselves remain unchanged. What has changed is that a commercial access agreement has now been added, together with updated pricing. This is intended to reduce the budget impact for the NHS and make implementation of the guidance more sustainable. As a reminder, let's remember that for type 2 diabetes, tirzepatide continues to be recommended when triple therapy with metformin and 2 other oral drugs is ineffective, not tolerated, or contraindicated, and when a GLP-1 receptor agonist would otherwise be considered. For obesity, it remains recommended in adults who meet the BMI and comorbidity thresholds specified in the original appraisal and following a gradual NHS rollout process. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.